All right, today we're going to walk through a patient's journey with a condition called beta thalassemia. We're looking at it this way because that's exactly what it is, a lifelong journey that unfolds day by day, starting from the very beginning. Let's dive in.
You know, for so many people, this whole life-changing journey kicks off with something incredibly small, a single drop of blood. It's usually part of a routine newborn screening test, but for some families, this is the exact moment their entire path changes. Okay, so what happens when that little test flags something? This is it. This is the moment of diagnosis. It's the critical point where families and their doctors start to unpack the reality of what it means to live with beta thalassemia.
So what is this thing? Well, at its heart, beta thalassemia is a genetic blood disorder. It all comes down to a tiny gene on chromosome 11. Basically, this gene mutation messes with the body's ability to produce enough hemoglobin. And you know, hemoglobin is that super important protein in our red blood cells that ferries oxygen all over the body. Now, while it can affect anyone, it's most common in people of Indian and Mediterranean descent. And that's not a coincidence. It's a fascinating clue that might point to an old evolutionary advantage against malaria in those parts of the world.
And this slide, wow, it shows you just how definitive the diagnosis really is. Doctors run a test called a hemoglobin electrophoresis, and the results are pretty much black and white. So take a look at the normal person column. Almost all of their hemoglobin is the adult type, HbA. Makes sense. Now look over at the beta thalassemia major column. See that? HbA is at 0. It's just not there. Instead, the body is stuck overproducing fetal hemoglobin, HbF. It never made that crucial switch from fetal to adult hemoglobin after birth. And that right there, that's the smoking gun.
So once that diagnosis is confirmed, we can start to look at the physical toll this disease takes. The body is basically in a constant state of battle against severe anemia, and you can see that struggle manifest both internally and externally.
This slide just powerfully illustrates the problem on a microscopic level. On the left, you see healthy, uniform red blood cells. But on the right, that's thalassemic blood. The cells are small, they're pale, and they're all kinds of irregular shapes. Now, these variations have fancy medical names, anicytoses and poikilocytosis. But what it really means is that these cells are extremely inefficient at their one critical job, delivering oxygen.
And you can bet that this internal struggle starts to show on the outside. A physician might notice a child is small for their age, they're pale, maybe a little jaundiced. Because the body is desperately trying to produce more red blood cells, the bone marrow actually expands, which can lead to a characteristic look called thalassemia phases. The liver and spleen also enlarge as they try to compensate for the failing blood cells. You might even see a bronze tint to the skin, and that's a sign of a major complication we're about to get to.
So, how do you fight this? Well, the treatment is a lifelong, truly delicate balancing act. It's this constant effort to manage the symptoms and prevent the severe complications of the disease from taking hold.
The absolute cornerstone of treatment is what's called the hypertransfusion regimen. This means getting regular blood transfusions, usually every 4 to 6 weeks. The goal is simple. Keep the hemoglobin levels high enough so the body can stop its desperate, damaging effort to overproduce those faulty red blood cells. When it's successful, this regimen allows for normal growth, prevents bone deformities, keeps the spleen from getting too big, and even helps by reducing how much iron the gut absorbs from food. It is absolutely life-saving. But there's a huge trade-off here. Our bodies have no natural way to get rid of extra iron. So with every single one of those life-saving transfusions, a significant amount of iron gets introduced into the body. And this creates a new and equally serious danger.
The solution to this iron problem is called chelation therapy. This is the other half of that delicate balancing act. It involves taking medication that contains chelating agents, which basically bind to the excess iron, allowing the body to finally excrete it. Doctors will typically start this therapy when a patient's iron levels, measured by something called ferritin, hit a certain threshold, or after they've had about a dozen transfusions.
Now, there are two main ways to go about this. The traditional method, using a drug called dysferol, requires a subcutaneous infusion, that's with a needle and a pump, for 8 to 12 hours a day, most days of the week. I mean, can you imagine? It's effective, but the daily commitment is just huge, and it has risks like vision or hearing loss. More recently, oral medications have come along, providing a much more convenient option. But of course, they come with their own potential side effects, like joint pain. So you can see, this isn't just a medical choice, it's a massive lifestyle decision for the patient and their doctor.
This brings us to a really challenging reality.
The complications that come with beta thalassemia don't just spring from the disease itself. They can also arise directly from the very treatments that are meant to save a patient's life.
This chart really shows you that complex web of complications. While the disease itself is definitely a source of issues, just look at that biggest slice. The blood transfusions, the primary treatment, are the single biggest contributor to complications. That's followed by the chelating agents used to remove the iron, and even the surgical removal of the spleen. It's a true cascade of cause and effect.
The danger of iron overload just cannot be overstated. When that iron accumulates, it deposits in vital organs, leading to devastating consequences like heart failure, liver cirrhosis, and diabetes. This is the cause of that bronze skin we talked about earlier, and it's worth remembering that before modern screening, these transfusions also carry the very real risk of transmitting viruses like hepatitis or HIV.
In some cases, the spleen becomes so overactive, a condition we call hypersplenism, that it starts destroying red blood cells faster than transfusions can even replace them. If this happens, or if that enlarged spleen is causing a lot of pain, its removal, a splenectomy, might be necessary. The trade-off, though, is a lifelong increased vulnerability to serious infections.
After exploring all of these immense challenges, let's look towards the future. Because medical advancements and a more holistic approach to care are creating brand new possibilities and offering real, renewed hope for patients and their families.
For a long time, the only potential cure was a risky stem cell transplant, which requires a matched donor. Now, gene therapy is emerging as a groundbreaking alternative, aiming to correct the genetic mistake right at its root. But the future isn't just about high-tech cures. Holistic care is just as vital. This includes genetic counseling to help families understand the disease and, crucially, patient education to empower individuals to become active managers of their own health.
And that management is relentless. 365. That's how many days a year a person with beta thalassemia has to think about and manage their condition. There are no days off from the infusions, the medications, and the constant monitoring. And this leads us to a final, crucial question. Modern medicine has done something amazing. It's transformed beta thalassemia from a fatal childhood illness into a manageable chronic condition. But as we continue to extend life, we have to ask, how do we also ensure we are creating a better one? The challenge now is to focus not just on survival, but on the quality of every single one of those 365 days. Thanks for joining me for this explainer.